Good afternoon. My name is Jamie Reed. I hold a Master's of Science in Clinical Research Management. I am a lifelong Democrat, a mom of 5 boys, 3 of whom were adopted out of the foster care system, and I am a lesbian. I am also the public whistleblower from a pediatric gender center where I worked, where I saw patients from the age of 3 until the age of 26, and I worked with nearly 1,500 unique patients. I worked in pediatric gender medicine for nearly 5 years, and I was once a true believer. What I learned is that these are interventions based on poor research, with poor evidence and poor outcomes. I believe that my time best today will be used simply explaining how a puberty blocker is clinically used and how it came to be used in children. 3 mental health providers in the Netherlands hypothesized that the reason why transsexual adults were not doing well was because they could not pass. Primarily, men could not pass as women. They hypothesized that they could intervene in early childhood to cosmetically help them look better as adults. So they devised a study giving a puberty blocker when children reached Tanner stage 2. They believed that the puberty blocker could be part of a diagnostic determination giving children, quote, a time to think. It did not work that way. It became a one-way pathway, and nearly every child ever put on a puberty blocker has gone on to cross-sex hormones. They tested this 3-part protocol. Step 1, a puberty blocker. Step 2, cross-sex hormones. Step 3, surgery. They tried this first on 70 children. So-called patient X is a young lesbian. In fact, 68 of the 70 young people admitted that they were same-sex attracted. As a lesbian, this concerns me because most of us experience profound questioning of our sexed bodies in childhood and adolescence. In the first study, 1 young person died. They died because the pubertal blockade meant that their penis never developed and they were unable to have the type of vaginoplasty that would invert a penis. Instead, the surgeons had to use a portion of their colon. They developed a massive infection and this young person died. The first study concluded that these patients might be feeling better because they actually completely switched the measurement scales. The British then tried to repeat the puberty blocker study in 2011. The outcomes were so poor, they refused to publish the results. The researchers found, quote, puberty blockers had not changed subjects' well-being, including rates of self-harm. Within the United States, a puberty blocker study has been completed. In a New York Times article on October 23rd, the reason why we have not yet read it was finally explained. Quote, U.S. study on puberty blockers goes unpublished because of politics, doctors said.
Seconds.
The leaders of this long-running study said the drugs do not improve mental health in children with gender distress.
Thank you. Did I, Representative Kessel, I mean.
Thank you, Mr. Chair. So I've heard a lot today about statistics and different information, and it sounds like there's a growing concern there's not enough research. Is there any other specific research that you can cite? Because I haven't heard anything else that says that it could be, to follow up to my question, safe and effective.
Absolutely. So when we look at research, we have to look at something called the pyramid of evidence. At the very top of that pyramid is something called a systematic review of evidence. Basically, it looks at every single study that's published, and they systematically review all of those studies to find out what the weight of the evidence is. Is it good evidence? Is it bad evidence? We have had multiple nations across the world complete systematic reviews of evidence. They've reviewed puberty blockers, cross-sex hormones, surgeries. They've reviewed everything, even binding and tucking. What they have found is systematically the reviews of evidence show that there is little to no statistical support that these interventions treat what they are intended to treat. That does not mean that individuals will not say, I, quote, feel better. We do not judge a medical intervention based, unfortunately, on an individual's response. We have to look at it from a systematic level. The countries that have completed systematic reviews of evidence are almost all primarily liberal northern countries in Europe. Finland, Sweden, the UK. The UK's systematic review of evidence took 4 years. The outcome of that study was to ban puberty blockers in a bipartisan manner from the use in England. Canada released 2 more systematic reviews of evidence just last month. They reviewed puberty blockers and cross-sex hormones. Both of those systematic reviews of evidence show little to no support for these treatments. When you have poor support for the treatment, you have to then look at how bad are the possible bad outcomes. So if we can't prove that it works well, we then have to make a decision, could it really hurt? And what we know is that we don't have evidence that they work well. And what they really hurt is that they sterilize children, they remove sexual function, and they destroy functioning endocrine systems.
All set. Any other questions? Representative Drew.
Do you know of any other models where people treat based on a patient's self-diagnosis?
No. And what's so challenging with this is that so many people today said things like this takes so long, that the diagnostic process is very, in depth, that they had to see a therapist. What I can tell you is that this diagnostic process, which is based on something called the DSM-5, so this is considered a mental health condition. The reason why we pay for this with our insurance is because it's in the DSM-5. The way that people actually diagnose this is based on written criteria. That criteria includes things like a strong desire to be of the other gender or insist that one is the other gender. Most gays and lesbians do this in childhood. The other elements to this diagnosis include a strong preference for cross-gender roles in make-believe. So if a child wants to play the prince or the princess, that is how the DSM-5 is diagnosing gender dysphoria in childhood. In addition, if you prefer to play with toys of the, quote, other gender, if a woman, a girl, grew up wanting to play with Legos instead of Barbie dolls, she would meet the criteria in the DSM-5 for gender dysphoria. In boys, if a boy rejects typical masculine toys, games, activities, or prefers to play with girls, they would meet criteria for gender dysphoria in the DSM-5. When I have read all of the criteria in the DSM-5 to gay and lesbian adults, they meet every single diagnostic determination. This is the most homophobic protocol I have ever seen devised, and we were once forcibly raped to make us straight, and we were once chemically treated to make us straight. And we are now using the current DSM-5 to say if you are not a stereotypical boy or girl, you meet criteria for gender dysphoria.
Other questions? Yes, Representative Miller.
Thank you, Mr. Chairman. Does meeting those criteria force one onto these hormones?
No.
Thank you.
No. So what happened?
You answered the question. Thank you.
She can speak.
Did you want to elaborate? Or?
Yes, absolutely.
Okay, go ahead.
So what happens is when we have young people, children, who do not fit the stereotypical role of their early childhood, what used to happen is those sissy boys or those masculine little girls would be brought to a therapist, and that therapist would tell the parents whether or not they should socially transition the child. What's happening now is that older adolescents, we see this as a true social contagion as well. Older adolescents are identifying and stating that they meet this criteria. They will come in to a therapist, and the therapist does not do anything else but say, do you identify as trans? The young person says, yes, I do. And then in my own center, that was enough. And yes, children were receiving cross-sex hormones and puberty blockers after one meeting with the child therapist and one meeting with the pediatric endocrinologist. It was a very rapid protocol. So yes, you can essentially walk yourself right in and get yourself on hormones.
Anyone else? One follow-up, one question? Yeah,
Thank you,
go
Mr.
ahead.
Chair. So that brought up a really good point. I mentioned before that Dartmouth had it on their website that it was the first thing that they do when it comes to it was the hormone and the first step in their medical step. In your professional experience, how is it broken out in most other places, or in your experience, what is it? How is that process done?
Thank you for your question. I was really appalled that Dartmouth could not answer the question how many children they have medically transitioned. I can let you know that between 2019 and 2023, they medically transitioned 76 patients at the Dartmouth Hitchcock Medical Center. At the Dartmouth Hitchcock Clinic, they medicalized 3 patients. They wrote 353 prescriptions. They billed close to $100,000 in submitted charges. This is over a 4-year period, and this is only the patients that they correctly billed to insurance. So this data is there. I cannot believe that they would not answer the question on how many people that they have done this to. However, in a center like that, I also worked in a multidisciplinary center exactly like they have set up at Dartmouth. The WPATH guidelines themselves essentially state if a child states that they are trans and at least one parent or legal guardian agrees with that assertion, then that child can be medically transitioned, no questions asked.
Okay, any final questions? Representative DeLamus.
Thank you, Mr. Chairman. You referenced the cross-sex hormones. Do puberty blockers, does a puberty blocker followed by sex hormones result in eventual permanent sterility?
Absolutely. If you follow the protocol correctly, as it was created by the Dutch, you start a puberty blockade at Tanner stage 2. At Tanner stage 2, the penis is not developed, the testicles have not dropped, and the testicles do not have the pathways to create sperm. So women are born with all of our eggs that we're ever going to have and ever be able to use for our fertility. Boys actually have to grow the pathways into their fertility. If you block at Tanner stage 2 and go on to cross-sex hormones, infertility and sterility is 100% guaranteed. In clinical theory, we were hypothesizing that if we go in and harvest a portion of that testicular tissue and freeze it, if that young person later decides that they want to have biological children of their own, what the hypothesized clinical idea is that we could actually implant that testicular tissue into a pouch on the abdomen, let that testicular tissue revascularize and grow, and see if it could later go through the process to create sperm. We have no protocol to do that. It is guaranteed that if you follow this protocol correctly, a young male at Tanner 2 cross-sex hormones will be sterile. It is a true human rights question in my mind if proto-gay young people, I believe it's a human rights violation to take away from my community, from proto-gay boys, the right to their future fertility. I think it's a human rights violation against them.
Follow up? Is it a quick one?
Yeah, thank you.
Okay.
At what age does this sterility occur? I mean, is it later? Is it earlier than I would imagine? I don't know.
So Tanner stage 2 is not an age. Tanner staging is how we determine how far along someone is in puberty. Tanner stage 2 in boys, I think we actually even heard a young man was started at the age of 10. Most girls start puberty earlier, boys start puberty later. We actually have a whole chemical question right now. Younger and younger ages are being seen in girls. There's an issue here that does need to be looked at. Most girls will start puberty earlier than boys. if you catch the boy at Tanner stage 2 and we give that puberty blocker, as soon as we start dosing with that cross-sex hormone, that fertility is essentially damaged for life. In my center, we were putting boys on a puberty blockade and leaving them on that. I think also you heard from some older trans identified men.
Yes.
Seems to me that the answer is going way beyond the question, which was at what age, and we are now talking about theoretical treatments. And I'm a little concerned about those people who have been waiting for almost 2 hours to get to the next bill.
Point of order, she can speak. She has a right to speak.
Well, she does, but
Yes,
yeah.
sorry, age
But-
is just
but-
not
but
the
again,
answer. It's
please
based
focus
on
the
clinical.
question that was
Yeah.
offered.
Yes, the answer is basically there is not an age. This is based on clinical guidelines for when Tanner stage 2 occurs.
Any final questions? I would like to move on.